here. Myself, Manasi Mahalingam, will be hosting this today's program. On account of Low Vision Awareness Month, Optometric Association of Tamil Nanbargal, OATN, and American Academy of Optometry India chapter has come up with its first of its kind panel discussion on integrating low vision care into primary eye care. I feel this is a very important topic to discuss on account of this Low Vision Awareness Month. It gives me immense pleasure to welcome the esteemed speakers and also all the delegates for this panel discussion. For the success of this webinar, I kindly request every participant to mute their audio as well as video to avoid the distractions. You can also post your questions in the chat box, which will be discussed at the end of the session. Now, I welcome the ever enthusiastic, the President of OATN and AAO India chapter, Dr. Jamil Reswana, to speak about today's program and also to introduce the first speaker. Over to you, ma'am.
Thank you, Manasi. This is indeed a great moment. Two key national bodies coming together, the India chapter of the American Academy of Optometry and a pioneering state association, the Optometric Association of Tamil Nanbargal, that has set standards for optometry across states and stands tall as a leader. And we've all joined together for a great cause. And the World Vision Report says that with over 2.2 billion people suffering from visual impairment, we are also aware of the fact that there is a dearth of eye care professionals across the globe. So it is imperative for each one of us to step up our services to combat vision impairment and also to empower ourselves with the skill set and knowledge required to serve individuals with low vision. And we have two great professionals on this panel today. They've inspired all of us and they continue to inspire us and the entire global community through their professional services and scientific contribution to low vision care. So the very first speaker that I take great privilege in introducing is Dr. Krishna Kumar. Of course, you see a whole set of accolades on your screen. Dr. Krishna Kumar, the former principal of Elite School of Optometry and a well-renowned, I would call him a reformational educationist. His leadership has transformed institutions to standardize optometric education. His passion for clinical optometry with specific emphasis to low vision care has taken him to a level where he's providing geriatric eye care services at the doorstep. And that's the name of his current entrepreneurship venture, apart from providing his expert services to optometry education as a freelance educator and consultant. And it's time to listen to Dr. KK's nuggets of wisdom in this panel. Over to you, Dr. KK.
Thank you. Thank you, Rizwana, for kind words. I'll just share now. Okay. Thank you. And indeed, I'm really privileged to be invited to give a talk, and especially a topic which is very close to my heart. In addition to it, it's also a great privilege to talk alongside with my senior, Vijaya Kumari. I think she has contributed enormously to the scientific world and to the patients. Thank you for that. First of all, the role of optometrist in low vision care and home-based care. Actually, we are talking it, and this 2022 itself is something very, shocking for many of us, because I remember the talks of Vijay Kumari way back in 2005 during the EVOC, wherein she was insisting that every optometrist should, a clinic, independent practice should try to introduce low vision care, and a lot of initiative happens from different quarters, especially from primary institutes this country. But still we are talking about it, means there is a great need for it for various reasons. So I take this opportunity to highlight some of my thoughts, and we're very, very keen that I should not touch any of the scientific material which is available, which talks predominantly focusing to the Western population, not really looking into the internal Indian issues. So I just trying to share what are my thoughts, which I collected over a period, and on these four fundamental questions. The first and foremost question, because probably that is the reason why we still haven't started even the primary low vision care. Do we need to offer primary low vision care is probably the first and foremost question that I feel any one of us should ask ourselves. The second question, are we offering such services probably without being aware that we are providing low vision care? Probably I will try to probe based on my experience on that. And what is the primary low vision care, if at all, that is defined by the WHO in different places, primary care, secondary care, and low vision care? Whether is it adequate to integrate low vision care into a primary eye care, or we have to integrate at least the primary low vision care, as WHO says, into our primary eye care services? And by asking some of the fundamental questions to ourselves, we see whether it is appropriate to venture into this low vision practice to the extent which probably I think will be appropriate. Maybe my next speaker will give you take you through what are the challenges and the solutions wherein. So do we need to offer primary low vision care? I don't think anyone will say no for it. Of course, everyone agree that there is a need. I don't know, somewhere something is stopping us to go beyond. Though we are well aware there is an increased number of people, every time we hear people say there is a huge number of people waiting for the services, the uptake is very less. I think these questions and answers are keep coming. But one thing all of us are very sure about the statistics which shows that there is an increased number. I don't think there is any second thought about it. And second thing, there are a lot more devices, maybe 20 years back, and today I think we can see there is a lot of technology-driven devices which is trying to enable various people with visual challenge directly to enhance as well as to give us an assistive devices. But who is going to spread this information for people who needed this? So naturally, there is a very important, pertinent issue which I feel, which we are getting struck, not only the patient, but we also as an eye care professional or vision care professional struck too. We think that spreading the awareness about the treatment is more than enough for a condition. Unfortunately, people also think that that is the closure, rather than thinking that beyond treatment, there is something called rehabilitation, where this low vision care really play a part. I think probably unless and until we see there is the two aspect of healthcare, one is the treatment, another is the rehabilitation care. Probably if we are convinced about it, there is a definite need to look into the second part of the story and try to educate the patients at large. With the technology, there is a widened scope. Actually, there was a time, I remember we were taught that if there is someone has got the vision less than 3/60, we were then told the prognosis of low vision care itself is poor. Today, with the technology, we can expand. That means there is a huge opportunity for optometrists to try to venture into see that it is not a narrow range of 6/18 to 3/60, but it's beyond that we can provide. As I told, even the assistive technologies like Orcam and smart glasses, which is there in the air today, is going to contribute, or it's contributing in a small level, which should contribute in a big level. And the last one, which is more closer to heart and which is true, is increasing geriatric population. We know with the lifespan is increasing today with 70, 72 years. Most of my patients whom I'm visiting today in the home care is between 70 and 100 odd years. That means predominantly all these people will have associated ocular diseases. So it means that they do have visual impairment, and the needs or activities of daily living actually push ourselves definitely to offer low vision care services, not only at our clinic, but also to the doorsteps of these people. Thinking that I have sort of convinced that it is the right time for us to venture into the primary low vision care at least, I thought the next question comes, are we not offering such services now to some extent? I feel yes, no doubt about it, but with some fringes attached to it. Means that we are not adequately offering that, as well as lot of times I realize that we are not aware of the specific goal or objective of offering such low vision care services. Even simple reading, a person comes with a reading difficulty, we provide a plus lens. It's also sort of a rehabilitation initiative, which only thing we have to expand it for providing them with a higher plus power and lighting, which also I've seen many of the people do it. But something else also we also provide the tins for glass and photophobia. All these things contribute to some extent as a low vision care or at least the vision rehabilitation care services. But we do miss out a huge chunk of area which are easier to adapt and follow. Like, are we aware that when we provide the services about the diagnosis fully and the natural history of that condition, the prognosis, its impact, and are we counseling them about various alternative to the treatment? Are we giving some input about the environmental issues associated with the difficulty which they face? Now, all these things, as well as referral criteria to the appropriate places when we don't have the know-how or the facility. That means we are offering, probably it's an opportunity for us to enhance it effectively. Now, very important, WHO already explains what is primary low vision care, secondary and tertiary eye care. We can just try to look into it and see where we can fit ourselves by asking some questions towards the end. Now, we all know primary low vision care. I'm not getting into the fine detail about what WHO talks about, who are the people should involve in it, but exactly I'm trying to tell the context of it. The screening of the low vision people, or screening of the condition leading to low vision difficulty, low vision problem. Environmental modification, if you find out those people have the low vision or the blindness, and referring to the appropriate people, or the three important aspects of a primary low vision care. I don't see is there any difficulty or any great learning is required if maybe few information, reading tips, keeping them from some of the experts. Definitely we can ensure that we can slowly get into it without much of the investment, probably investing of the time. If we do that, we can at least, according to WHO, take care of 20% of the people with low vision care. The secondary is the secondary low vision care, wherein we have to have the low vision devices, especially optical magnifiers and non-optical magnifiers, and offer the services to the patients who have been referred from the primary care. I feel we are taking care of almost 50%. That means if you're going to offer primary and secondary care services within your primary eye care services, you can ensure that 70% of the people can be covered. Of course, I really understand when I have interacted with many of the people why they can't venture into it. They say there are some difficulties. Probably the next speakers try to open up and give a solution for it. The tertiary low vision care, naturally today it's happening in predominantly in the tertiary eye hospital, wherein they combine all the possibilities to ensure the better quality of life for the people and the independency of those individuals. Now, with all these three keeping in mind, where do we fit ourselves? What more we can offer in India? I'm not going to give answer directly. I'm trying to see if we have answers for this question. Yes. And if you answer for every, at least more than 10 of it, if you say yes, then you are now prepared enough to go to the next speaker, listen to her and see how we can implement the low vision care services into your primary eye care service. Is it not possible for you to extend the service to members of the patients, your own family, your own family members and the members of your own patient's family who need, probably most of them, they are not coming to your services. Maybe you can always try to open up and ask whether you have elderly people who require services. That is where I see you can really pick up people even if they are not come. Or at least you can try to have some kind of teleconsultation with them and ask them whether they do have any of the difficulties wherein you can chip in, go to their place, and then try to develop the goodwill of your own patient. The second thing, screening the blind school. I know many of the institutions are doing, maybe the individual practitioners also can venture into it, and also for you to screen members of at old age home. I feel there are three definite places where the needs are very high or not been taken care. Look at the recent paper. It also showed the higher number, almost 30% who are visual impairment people are existing in the old age home. So at least we have, for people who are looking at why we need to start, If you have an S for it, these are all possible. I think we are ready to initiate and integrate the low vision care into our practice. The second question I felt is it possible for all of us to discuss the diagnosis, natural history, and the prognosis of the condition with the patient? I feel it is possible. I think most of us, maybe we have to have adequate information rather than having only the basic information. If so, if you're unsure that there is a condition, doesn't have adequate treatment, the prognosis is not good enough, and that is the time you can introduce to the people telling about the low vision care and the vision rehabilitation aspect of it to the parents, to the to the patient himself, so that they are at least be aware. It's a counseling part, and also share about some of the beneficiaries of such services within your own clinical setup or from some of the literatures. And also you can talk with the tertiary care centers who are offering the services. You have heard about some of the speakers who have given this information in some of the CMEs. Those are the things which you can do. It is not difficult. So is it possible for you to do? And also understand what are the difficulties in activities which they are doing in day-to-day life they do have, and what are the expectations they're having in relation to vision and the activities which they do. If you have all these questions and if you feel all these things are possible in your setup, that means you have one step more that you are moving towards integrating the low vision care into your primary eye care service. The last question which I feel we should, is it difficult for us? Is it difficult today to access to any of the optical magnifiers and also demonstrate to the people who require either at your clinic or at their doorstep? Is it difficult to give a hands-on correct usage of selected various devices, to schedule a day of low vision care services appropriately, at least to try to say at least weekly once, whether I could offer the services of low vision care in my clinic or monthly once? Is it difficult for us to do it to start with? Is it possible for us to have access to facilities in and around, especially tertiary eye care, low vision care facilities, so that you know which are the patients you require referral, you can always refer them. You also create a referral criteria for yourself so that you can refer people. Also, you can create a guideline so that other people can refer those patients to you where you can offer the service. For you to equip yourself, some of the few environmental tips which you can pick up, it's easy to offer whenever you visit these homes of those people. So if you have answered more than 10 questions, if you have answers are yes, and I think you are prepared now without much of investments towards low vision care integration. So I see role of optometrists in primary low vision services or role of optometrists in primary eye care services, whichever way. Screening of low vision at doorsteps or at your own clinic, doing a comprehensive examination, diagnose it and confirm the diagnosis with the help of your collaboration for ophthalmologists or hospitals, counsel about the disease, natural history, treatment, prognosis, explain about how the low vision care is going to help beyond the treatment, and have adequate basic low vision services, which I feel the integrated primary and secondary to some level of tertiary, depending upon your ability, you can try to add down the line, have a proper follow-up and referral to tertiary low vision care services within your own nearby places. I feel with these things, definitely, I feel there is a huge opportunity for us to enhance our services. Home-based low vision care services, which I don't say that I'm doing predominantly because I go by not by definition most of the time. What I realized in all my low vision care services or eye care services, so the geriatric at the doorstep, I go by their activities of daily living. Whichever the activities they want to do but they can't perform adequately, are those the things which I try to intervene with. That's all you have to do in these people once they have been diagnosed, been known the prognosis, everything. So I feel this will give an immense help. Today, this area is very vacant. People haven't ventured into it. It is going to be a great boon for bedridden people. It improves their quality of life. It should not be once in a while services. It should be a service that you have to provide. People should know that this service is available with you. So people will contact for the elderly people. There is a huge need of this service, uh, eye care services at the doorstep, as well as the low vision care services for the elderly. So both you can easily integrate. At least one day you can offer the services at your setup. Now, this, to sum up, I strongly feel low vision care is no more just improving the visual acuity. It is to bring in the quality change and enable the person independency in all his walks of life. It's no more just dealing with visual impairment. It is to focus on disability and consequential social handicap of the individual. So we join together to achieve the above goal by integrating low vision care into our optometric practice, by equipping ourselves only to serve millions of people who are waiting to be served at their own doorstep. Thank you very much. There is nothing equivalent to this. See the happiness of every individual when you offer the service, which already know. Thank you very much for this opportunity.
Thank you, sir. Thank you for sharing your amazing experience and also thoughtful points. And thank you for also pinpointing the importance of home-based low vision care, like in enabling the independency and about the integrating of primary as well as the home-based low vision care. Thank you so much. Now I call upon Ms. Preeta Ramprasad to invite the next speaker, Dr. Vijaya Gautwal.
Is my voice audible?
Yes, ma'am.
Okay, fine. Thank you, Manasi. So before I introduce the second speaker for the day, I like to thank Dr. KK for explaining the scope and for the thought-provoking lecture. Thanks to Dr. Rizwana and OAT and AAO for organizing this session to commemorate Low Vision Awareness Month. So today I'm truly honored to introduce the second speaker for the day, Dr. Vijaya Gautwal. Dr. Vijaya Gautwal is a prominent low vision specialist. She completed her undergraduate in optometry from Elite School of Optometry, followed by a master's in applied science and PhD from Queensland University of Technology, Australia. She completed her postdoctoral fellowship from Flinders Medical Centre, Adelaide, Australia. She has a vast experience in providing low vision care to many patients across all ages over the last 33 years. She was very instrumental in establishing the low vision services at LV Prasad Eye Institute, Hyderabad. She has published widely and has to have credit over 100 papers in peer-reviewed national and international journals. She has made over 150 presentations at national and international conferences. She was awarded the prestigious Constance W. Atwell Award for Excellence in Low Vision Research in 2002 by the Low Vision Research Group Committee at Fort Lauderdale, Florida. She is a fellow of the American Academy of Optometry, and she was recently awarded the Diplomate in Low Vision for Research by AO. She is Assistant Secretary in the Executive Board of the International Society for Low Vision Research and Rehabilitation. She is the co-chair of the Special Interest Group for Developing Nations of the International Society for Quality of Life. She is a member of the Low Vision Annual Meeting Program Committee of ARVO, USA. Her research interests include psychometrics, patient-reported outcome measurement, low vision, and specifically pediatric low vision. Currently, she is the head of Outcomes Research Unit and a senior faculty, head of the Outcomes Research Unit at LVPI and senior faculty at Bausch & Lomb School of Optometry. So it is truly my honor, ma'am, to introduce you. Over to you. Today, she's going to talk to us about the opportunities and challenges that exist in implementing low vision care services in primary eye care setup. Over to you, ma'am. Thank you.
Thank you, Preeta. Thank you so much for that kind introduction. And I hope I live up to that. And thank you, Rizwana, Sarika, for putting this wonderful program together. And thank you, Krishna Kumar, for that wonderful talk. So you made my job easy. I'll share my slides. Let's see. Visible, right? My slides? I'm audible
Yes,
also?
ma'am. Yes, ma'am.
Okay. So following from where, taking off from where Krishna Kumar left off. So what are the opportunities and challenges that we are facing while implementing low vision services in primary eye care? So as Krishna Kumar already alluded to, in the WHO tier system, primary low vision care can cater to about 30% of the needs of the population. And what does WHO suggest? At the primary level, the field workers, the community-based workers, they can identify and refer patients with low vision to the next service and also advise on environmental modifications. These tiered systems have worked very well, and they work very well in the developed world, especially in UK, Canada, and Australia. Just about 20% of the patients really need to be seen at the tertiary level, and 50% can be catered at the secondary level. Now, so what do we mean by primary eye care at low vision services at the primary eye care? What does it mean, and where are they located? So basically, they'll be located in the primary health centers. So we have an opportunity because these are community centers, and so usually you'll find the community-based rehabilitation personnel there. You'll have community-based outreach services, and like Krishna Kumar mentioned, school screening. So school screening is a beautiful opportunity. Why? Because you can have vision screening, you can have assessment of functional vision, you can refer to the next level of low vision services. But simple low vision devices, low power magnifiers can be provided. One can also offer advice on environmental modifications and non-optical interventions. So what is the set or the kit that is required for primary eye care? Not much, as you see, in terms of ophthalmic equipment, you just need a pen torch, easily available. And then you have the WHO low vision kit. In addition, you just have these low vision devices. All you need is simple hand magnifiers, low powered. You have stand magnifiers, again, just about up to about 40 diopters, and 2 telescopes, just 4x and 6x. This is the recommended devices that are required for providing services at the primary eye care. Now, there are 3 basic things. When one, like Krishna Kumar also mentioned, when you consider providing services at primary eye care. Mind you, sometimes people are not trained. More often than they are not trained to provide the service. So you don't need training. It's more of a common sense. So the first thing is make it bigger and bolder. And this is, it plays relative size magnification. So you see here, so you see these large print, you see this large print calculator or these large dial phones, large alarm clock. And in terms of bolder, you see something that is written here compared to this. So you see it is written large print and it is also in good contrast, right? So you can have these felt tip pens, simple things, right? You have a large dial clock, again with good contrast, black numbers on white background. You have large print books. So this is about making things bolder and brighter. The moment you're going to make it bolder and bigger, it's going to be easier to see. So that is the simple principle there. The next is color and contrast. As you can see here, so you see here, the text here on the right, you can see it is good contrast. Compared to on the left, you see it is very faded. So in schools also, if you see still majority of our schools use blackboards. So in the first period, because it's morning and it's the first class, at that time the board is pitch black. There's no problem there. But as the day progresses, somewhere in the, let's say, the 4th or the 5th period, the board turns gray. And the teacher continues to write on that with a white chalk. And then the contrast is poor. So a simple thing can be told. They can use a wet duster to rub the board instead of using that dry duster. That simple thing will make it easy. It will make it easy for all the children. Again, a principle of contrast here. You see, this is reverse polarity. So you have white text on black background. You can see here, see the handles against the background. So you see they're standing out. Again, you see the doors. You see these railings. So it's easier for patients to be able to find the doorknob because it's against the contrast. You see a cutting board here. See this lady? So she's using cutting board, 2 different contrasts. Again, you see these for vision stimulation material. Again, it has to be good contrast. You see here, so you see this on the right side, you can't see the white rice on the white plate, but the white rice on the banana leaf is very easily visible. Again, white rice on the red plate. Again, you see this lady here, she's giving tips on contrast, color and contrast. So you see these vegetables you can use. So you see this cutting board again. So these are all simple things that can be advised, and it is not rocket science. But many a times we don't pay attention to these simple things that can make life easier for vision impaired patients. The third thing is improve lighting and using lines and trying to lift whatever you want to see. Now, improve lighting. So you look at this gentleman here. He's reading with a spectacle magnifier, but look at that. There's a task lighting there. So there's an overhead reading lamp with tube light. That itself increases the contrast. So because of that, it makes reading easier. You see here, so you see this line guide here. So what happens is it isolates the line and it increases the contrast. So it makes reading easier. You see here again, so the person is reading with a LED stand magnifier, but look, he's lifting it. So he's using a reading stand there. If he didn't use the reading stand, he'll have to bend. And if he bends, then he has these neck issues and postural issues there. So it is very important when you give these LED stand magnifiers, or look at even this. It's a non-LED stand magnifier. But again, it needs a reading stand because of the posture there. You see here, see the board. And so you see this line there. So for the child to be able to track. So it is so important. So you improve lighting using lines and trying to lift whatever you want to see. So who are these people who are going to be able to provide services at primary level? Obviously, we do not have many optometrists at that level. It can be vision technicians. And these are gatekeepers because they are the entry point into low vision rehabilitation. Where can we find these people? They can be found in private practice. They can be in the government sector. You can have them in private eye clinics, optical outlets, or NGOs which are working for vision impaired, or it can be a visiting service like Krishna Kumar is doing, right? Or you can have them in private eye hospitals. So at the primary level, also so much can be done. Now, the logical question is, why is this not happening? When it is so easily achievable, what is the stumbling block? Because low vision care in early stages is not viewed itself as basic optometry. And that is the primary problem. And very sadly, there is lack of recognition that optometrists can provide excellent low vision care at primary level. And there is lack of awareness about ophthalmologists, among ophthalmologists, about role of optometrists, and lack of professional peer support group and mentoring in low vision. So these are some of the basic reasons why this is not happening. Now, so since we know why it is not happening, what are some of the strategies that can be employed to address this? The first one can be probably we can adapt the smart sight model, which was launched by American Academy of Ophthalmology somewhere in the early 2000s. We can liaise with and engage with NGOs working for vision impaired. We can educate students like we are doing now to increase their clinical experience, and educate ophthalmologists and general practitioners so that there is improved referral mechanisms. The problem is because there is no, we are not closing the loop there. So what is happening is there is no feedback mechanism. So they have no idea that patients that cannot be served by them can be referred to low vision services. And it's also important to educate optometrists like we are doing now. We are having continuous professional development programs. You can have webinars, you can have online webinars, online work. You can have workshops, you can have conferences, and like we are doing now, the public awareness campaign, and this is the Low Vision Awareness Month. And very important that we establish a low vision society. So if we establish a low vision society, at least we can have a list or a directory of low vision care providers, have them on the internet, and at least people who can access the internet can at least find a practitioner. Suppose I have a patient and I do not know where to, at least I can give that address to that person, to the patient, and they can probably go and seek the services there. So what is the smart site model? So it has 4 levels. Level 1 and 2 is a must for everybody. So what is level 1 and 2? It is basically to recognize and respond and provide basic low vision services. So recognize and respond is a must for everybody, regardless of which cadre of eye care professional, both ophthalmologists and optometrists. So it is important to, if you recognize, and then you have to refer for appropriate low vision services. In the second one, it is providing basic low vision services, like I told about lighting, magnification for close work, filters, prescribing low power magnifiers. But the third and the fourth level are where it is a comprehensive low vision evaluation. And fourth level is all at the tertiary level services, where you can get into vision rehab training. It's not necessary for everybody to do this, not the third level, not even the second level, but the first level is everybody's business. So like I just said, so because also important to remember that the activity limitations or the functional difficulties may begin at visual acuity just less than 612, not anymore 618 in the better eye. So, and what do you do at that time? At that mild low vision, it is good refraction, just probably higher ad, that should do the wonder. And then probably if there is issues with contrast sensitivity, you can have, or mobility issues because you have assessment of visual fields with you. You can refer for O&M training if required. And you can have, so not everybody may you can have portable perimeters. There are so many portable perimeters these days. And you can have contrast sensitivity charts. It's not necessary for everybody to have Pelliropsin. You can have flip books, you can have Lee symbols in case you have children that you're referring to. So from where do we draw the inspiration from? So if you look at the literature in primary eye care for children, it has worked wonders because there has been these measles immunization, early treatment of simple eye problems, congenital rubella through immunization. So there has been early identification and referral of children with sight-threatening diseases. And so in that, globally, what is available is the primary healthcare center workers are available, and you have these community health workers, and then so you can also involve teachers, religious leaders, community leaders. So it is more of community participation, and then regionally. So this can vary across regions. In several regions, you'll have midwives, CBR workers, traditional healers. You'll have refractionists. You'll have volunteers. So for childhood blindness, this has worked very well. And so what have they done? They've used didactic lectures, role play, problem solving, and they've had slides, manuals. And so what is the motivation? Why would people do this extra work, Because there is career development plans, and there's continuing medical education, and there is, so they emphasize on promotion of success stories, and they use media to promote this. And they act as ambassadors for childhood blindness. And the cost is very relative compared to the change that you can bring about in children with vision impairment. So there are our opportunities. It's important to hope. So in primary eye health care at community centers. So in every district, I think for a 1.25 million population, you'll have a community health center. At that center, you'll have these primary eye care workers, right? They'll be named differently. nowadays, ever since I think for the last 5-6 years now, so you have these Ayushman Bharat Health and Wellness Centers. So it's very important to integrate and see the people that are working at that level. And also school screening programs. Now, been there as a part of the National Program for Control of Blindness since 1994. And because they are the first point of contact and they interface with population in rural areas. And the PMOs or these ophthalmic assistants that are there in the government sector, it's a hybrid program you can run them. Some of them can be didactic lectures and some of it can be, they can have hands-on sessions. So you can train the vision technicians in vision centers. They can be in the private sector, they can be in the non-government sector. So that way they have a new career path and professional development programs can be done. So that way there is task shifting that's happening. And they can connect easily to base hospitals through teleconsultation. That way we are making integration very easy. So it's just an add-on, right? What are the benefits of doing this? So you're providing service on the spot, like Krishna Kumar alluded to. So it's at their doorstep. So savings, lot of savings in terms of cost of travel. Let's say mostly all these retinal degenerations, dystrophies, they are running from pillar to post for no reason. So they are saving. So you're saving the cost of travel, the anxiety, and it's a load of visual disability in the community and can follow up. Now, so it sounds very simple, but it's not happening clearly. So what are the challenges? Now, we all know that we are adequate, we are short staffed, right? So we do not have adequately trained optometrists. And so if you say add-on integration, it's easier said than done because it creates an overload on those primary healthcare workers. And it requires good coordination among the ophthalmologists, the community health workers, the purpose health workers, the ASHA workers. If we have to address, and we also address the gaps in the referral system so that there is, again, they're closing the loop, there is continuity of care. And also it is very important that these people are given access to the inventory of custom-made spectacles. Suppose, let's say an ad +4 or something. They may have only up to +2 or something like that. So it's important that they have the access to the inventory and simple low vision devices. So they can have high-powered spectacles, even aphakic glasses that people were having earlier. Even if they stock that, they can act as spectacle magnifiers. So, so those are the challenges at the level. Now at the patient level, what are the challenges? So you have social stigma. We all know this because it is the acceptance of services. Once you know that this treatment, there's no treatment for this condition, there's poor acceptance of services and low vision services in the community. So it's so important awareness regarding service and benefits. And then the practitioners, regardless of who they are, they have to be very comfortable, with integrating these services. Clearly, there are gaps in coordination. So because entry level, if there is a filter for entry level in schools, because studies have shown that vision impairment in school children is between 6 and 7%, both in North and South India. So it's so important that there's a filter there. So you can catch children right at the entry level itself. So again, coming to the patient-related, so they're assuming or being led to believe that nothing can be done. They may have cognitive impairments. They may not self-refer because doctor did not tell them. They may not think that they have adequate resources to self-refer. They do not know. And they do not think that vision impairment will anyway interfere with their quality of life. And as aging, so as elderly, they think that anyway vision impairment is a part of the aging process. So that needs to be dismantled. Then access issues. They can have mobility. So like Krishna Kumar is doing, he's taking these services to the doorstep. Affordability issues. And then personal factors. They can be cultural issues, language, and then they can be comorbidity. So they'll have physical limitations. They'll have hearing impairment, and they can have cognitive issues there. So lots of other things are there. And sometimes it's the family which is impeding. They could facilitate, or they could act as a barrier to the use of services. And in general, men have a greater tendency to withdraw and less willingness to learn new things. So what are we doing about this at Elite Prasada Institute? So as you can see here, we follow a pyramidal model of eye care across all our services. And if you see here, we have vision guardians at the base level. So these are people in the community, either the community leaders, any person at the community level who's creating awareness about eye care services in general. There is nothing, no literacy, no training, nothing is required. So sometimes they are family members of people who have benefited from services. Let's say somebody underwent cataract surgery. So they become ambassadors, and they are the ones that are promoting and about eye care. So they are the ones that will refer to the vision centers. The vision centers is for a 50,000 population. So again, these are staffed by our vision technicians, and we have about 200 of these vision centers spread across 4 states, Telangana, Andhra Pradesh, Odisha, and Karnataka. Then we have these secondary centers, tertiary centers, and the center of excellence. So this is the vision centers. So we have optical low vision services, we have our community-based rehabilitation services, and they will refer to the secondary centers. This is just where our low vision rehabilitation services are located. So you can see we are pretty spread out. And if you see here, you see this. So this is our centers where secondary center, but a vision center is attached there. So you can see, so the vision technician is the vision technician itself is giving some amount of training in use of the telescope, assessment of telescope, assessment for stand magnifier. See, you can see a gentleman here reading with a stand magnifier. You can see this child with a reading stand. And here this child is using a dome magnifier. So these patients need not be referred to the next level. So they don't have to come to see us in Hyderabad at all. So this part of the primary eye care services is dealing with low vision services. So these vision technicians are trained by us. So so we give about, now we've been doing some hybrid model where about 1 month is online and then about a month hands-on. But earlier it used to be just come to us for about 2 months and then we train them, because refraction and training. So it is just about sharpening their another few skills there, talking about environmental modifications, low power magnifiers. So it's, like I said, it's not rocket science. It's just about motivation, common sense, and that creates wonders, because we are able to serve a large proportion of the population. So this is the kit for the primary level services that we have. And thank you so much for your attention.
Thank you, ma'am, for such an enlightening presentation. And thank you for also sharing the impact of basic environmental modifications which can make the lives easier, and also for sharing various brilliant models. And yeah, it was very thought-provoking for me as well. Thank you so much. And now I call upon Dr. Aishwarya to introduce the next speaker, Ms. Sarika. Over to you.
Thank you, Manasi. Thank you so much. So those two were excellent talks. And after these 2 talks, I'm quite happy to introduce Sarika here, who's our 3rd speaker for the day. Sarika, who I'm sure will add more to this interesting session, has more than a decade of experience in low vision care, both in teaching as well as in managing patients. You can see the various accolades she had accrued in the last few years, which on the screen here. She's currently heading the low vision department at Shankara Nethralaya and is also instrumental in commencing the visual rehabilitation services at Shankara Nethralaya. She is the first Indian fellow of American Academy of Optometry in the field of low vision for the clinical category. And she is also the proud facilitator for World Health Organization's documentary on low vision rehabilitation. She is also a contributing member for the ILOCS. She all of us know that she has organized and co-organized many workshops and conferences in the past. Very happy to see you here at this stage. Sarika, over to you. Eager to listen to you.
Thank you, Aishwarya. Thank you, OATN and AAO for organizing this. Thank you, KK sir and VK ma'am for joining this session. So I just start sharing my screen. My screen is visible?
Yeah.
Yes, ma'am.
Yeah. Hope it's in slideshow mode.
Yes.
Good evening, everyone. Yeah. Good evening, everyone. So today I will be explaining on what is the importance of low vision care services. Hope you all are enjoying this session and you understood what is the primary eye care service and how to implement it and what are the challenges, all this from Dr. KK sir and Dr. VK ma'am. Now, beyond primary low vision care, so what is next and what are all the possibilities and what is the extent of low vision care services that we can provide? So first, statistics of visual impairment. So it is really shocking and it is a little bad news that India is one of the leading country with number of people having more number of people having low vision and visual impairment. So shockingly, it is like in the top 10 countries, it is the number one and 275 million people. I just want you to see the third ranking. So apart from India and China, everyone resides less than 50 million. So this is where it was like a bit hurting and we need to do lots of awareness programs and need to have lots of insight into this to bring down this number and we need to have lots of service, especially in primary eye care services, to reduce the number of people turning blind. Because, yeah, I'm going to say how it is possible. So, according to National Program for Control of Blindness, NPCB, this is a very latest report, 2019, and the World Health Organization report is 2021 report. So they have done a very big cluster of studies in all the majorly populated districts of India, and they have found out what is the most prevalent cause and what is the prevalence of low vision district wise, everything. It is a very big report. So from this we understand more than 68% it is a treatable one, and again more than 10% is preventable, and including the ophthalmic services we can prevent more than 80% of it. So only less than 10% is unavoidable blindness. So there is a huge demand and there is a huge need for optometrists and ophthalmologists to look into this. Similarly for visual impairment. So more than 80% it is treatable and preventable. So this is where, yeah, we understand what is low vision. We know the definition very well. It is less than 6/18 to light perception. Why I'm saying this and highlighting this particular line is unless and until the patient is going to have at least light perception, we can do lots. There are lots of augmented reality kind of devices and the latest devices which will improve the vision from HMCF to 6/18. You won't believe. There are evidences which I'm going to share. So it is very much possible that we can do lots even for people with just HMCF vision. Yes. So visual field as less than 10 degrees also we can do lots. So they are no more blind. You cannot treat them as blind. They also should not feel that they are blind. So they are just low vision and we can do lots about them. So these are the categories of low vision for which concession and benefits the government is giving according to Ministry of Social Justice and Empowerment. So basically, just a touch upon what are the conditions causing low vision. It can be central field loss or peripheral field loss or overall blurred vision. And these are simulated pictures how a person with low vision is going to see the world. Again, it's $100 million question. That's how I always used to say. And it is my lifetime ambition to understand how my patients see this world. No one can tell this. So we should create some tool and really understand how exactly your patients see the world. And then only you can do your best. So these are some of the simulation to basically understand how a person with central field loss or a peripheral field loss or overall blurred vision, patient would see this world. Yes, the patient is undergoing lots of psychological status the moment they understand that they have vision loss, which cannot be treated. So anxiety, anger, depression, and low vision care helps them here to make them understand and accept their condition and move forward in their life with confidence and motivation. So I feel we have a big role to play there. And a short introduction to clinical assessment, what all we do in the clinic. We take a very big history and a very detailed history. We tell you and help you to understand what is the primary visual need of the patient. There can be 100 difficulties. Okay, I just want you to understand what are the difference between difficulties and need. So you should make sure what is the primary need that the patient have. It can be more than one. So you need to sort out that to give the best management. And it can be from starting from the day-to-day activities, distance, near, computer, mobile, mobility, photosensitivity. Sometimes it can be like earning, and as simple as cooking tasks, self-grooming, organizing things. It can be anything of this. So you need to identify which is the primary need of the patient. So depending on the patient's occupation and the visual condition, it can be any of these. So we do a series of tests to understand their visual acuity, contrast, and field of vision and the refractive error. So moving on to low vision devices, we know like already we have seen enough number of devices from the last presentations. I'm not going into the details of this. I'm just telling you the crux of it. So these are the devices that we have from last decade. So telescopes and CTV, binocular telescope, spectacle model, binocular, all this, which can improve the visual acuity, say approximately 2400. And that is a minimum visual requirement so that you can work on them. And these are some of the optical devices for which at least the visual acuity has to be better than N36. So these are some of the non-optical devices where you can work even with patients with no PL for signature guide and no text and other things. So coming to this decade, mouse model CCTV and portable CCTVs, desktop CCTVs, for which the minimum visual requirement has to be at least N64. And there are CCTVs which work for both distance and near, so which can be a portable model also. So this will give more than 50 times magnification and helps improving the visual acuity. And suppose if the vision cannot be improved with these kind of devices, we can go for auditory devices also, like buddy player and classmate reader for blind and low vision patients. And there are computer softwares which can help patients, so for low vision and blindness. So there are inbuilt modifications in computer and magic screen reader softwares. So there are JAWS software and NVDA and so many text reading software, screen reader softwares for complete blind people. And there are mobile softwares. So previously, last decade, we had only very few mobile phones which can work for low vision people. Nowadays, everyone has a smartphone. In all those, we have lots of apps, TalkBack, and so many apps like 6x6, Be My Eyes. There are n number of apps which can help these people. In the next decade, we are moving into virtual and augmented reality kind of devices. We know there are lots existing. I have a few things which I can share in this presentation. So virtual reality can be defined as use of computer modeling and simulation which help a person in interacting with the artificial 3D environment. So this is one of the study. It's a part of my PhD which we worked on. And this is Oculus Rift CVA with Oculus Touch controllers. So it has a headgear and with hand controllers, where we tried simulating a virtual bank environment. These are some of the snapshots of the environment for assessment of various visual parameters for a patient with low vision. We tried on normals, and also we created a scoring system to understand how it works. And a small video. we tried understanding the distance contrast, near contrast, and the patient is using the hand controller to identify a token which was slipped. And this is to understand the hit rate. The patient is walking towards the counter to deposit its challan. So whatever we do in a bank, we tried creating that virtually, and we made the subject do this task. So virtual reality is different from augmented reality. We know that. So virtual reality is something like you're not connected to the real world. You are in the virtual environment, and the people try to do some task. And augmented reality is nothing but the real world, what you see just in front of you. So augmented reality is a live direct view of physical real world environment whose elements are augmented by computer generated sensory input, sound, video, and graphic data. So you can do whatever you want in that, depending on the app you use. So we used a Samsung Gear headset where a smartphone is connected. In that, Relumino app is there, which gives a bright, enhanced view of this real world. So this is a small video on how people see through this. So there is an adjustment on the side through which you can do magnification and brightness adjustment, contrast enhancements. So we can do zoom in, zoom out, and this is how they see this. So patient with as less as HMCF vision is improving to 6/12. So this is the data we have. So there is a significant amount of improvement in the distance visual acuity and also in the near visual acuity. And there are lots of children with complete corneal opacities who are also getting improvement in that. So these are the real verbatims from the patients. So they are very happy with the device, and they say it is very useful in their native language. So this is a wonderful Tanjore painting. I wanted to show this especially because this was done by one of the patients with visual acuity of 20 by 1200. So which is approximately 6 by 360, and which improved to 6 by 30. And we did a questionnaire also, and we understood there is improved quality of life score with this kind of device. So apart from this, yes, we have lots of training and techniques to give rehabilitation for those who have little vision and those who have no vision. So SNTP training for patients with central field loss for both distance and near, sighted guide technique, mobility training, smart cane training, all these we can give. So in case of daily living skills, right from waking up in the bed, there are so many devices. Ma'am showed most of those. So starting from alarm, clock, and tactile clues, braille tags, notex for identifying currencies, cooking, measuring, food arrangement, pouring liquid. So there are so many tasks that we do in a day. So for all this, there are lots of gadgets. We give training on that, so to make them independent. And there are lots of concession benefits. So every patient must understand the availability. So availing these concessions, and not it is their wish, but still they should know, they have the right to know that these are the concession benefits that they get from the government. And multidisciplinary approach is mandatory. So for low vision services, comprehensive low vision training, opticals, non-optical devices training, assistive devices training, independent living skills training, counseling and referral services, early intervention and schooling guidance, braille training, computer training, mobile technology, employment assistance, all this has to be done. So appropriate low vision care service can make a person happy, confident and independent. Thank you.
Thank you, ma'am, for sharing this intuitive presentation. It was, and also for sharing the importance of assessments and the evolution of low vision devices and the changes it has made in the people's lives. Thank you so much. Now, I think we could have the panel discussion. I'll just share the screen with questions. The first question is to Dr. KK sir. What are the perceived barriers in implementing low vision care in a primary setup?
I think it's a very important question, but already been enumerated by Dr. Vijaya Kumari. But I want to add some of my experience and what exactly happening. One of the biggest barrier, I feel it is from the mindset of optometrists. I feel the perception that low vision care services is equivalent to what we are offering as a dispensing or refraction care or the binocular vision care or the primary eye care services. I feel these two are different things. What we need to expect from here is different from what you are actually getting it from the services which you are provided, which I have enumerated before. Because it is, I always feel it is like a person who is getting into the healthcare services, you will be recognized only with years of services. Only people will recognize you maybe at your 30 or 35 years or so, after putting years of services and things. Unlike for someone in IT industry where the services been immediately been recognized. I feel that is the case in case of low vision thing. Probably I feel the biggest thing is the eye care professionals' perception. Not even I'm talking about awareness. Today, awareness is there, but there is a big barrier how they perceive this as to be a successful one. Because I feel if we can transform that, what I am going to get out of this whole service, I feel the great goodwill and the long-term benefit which you are going to reap from this will be the service, which will be the big barrier which you can overcome easily. The second barrier, according to me, is the time which we need to spend for this. A lot of time we say, despite all the technology, the time should be there for all of us. But unfortunately, technologies, neither our mobile phones, nor our speed trains, nor our vehicles which we are processing, doesn't give us the time to take care of ourselves and our own people around us. I feel somewhere we have to introspect on this time factor and the time which we are going to, quality time which you are going to spend. I feel there are solutions which is lie there in most of the eye care professionals, especially optometrists, both independent as well as the young people who wants to get into this profession. There is a huge thing that we need to do. So I feel the strong barrier is the, from the perception of the, see, once if the eye care professional are well aware of it and they can overcome the barriers, I don't think it is difficult for us to bring in change in the people who need to uptake it. Maybe I feel the fundamental thing. We, as I told before, if we can shift our thought process that there is only treatment and only treatment is the positive entity. But if we can say that every healthcare services include two components, one is treatment, another is rehabilitation. I feel if we can continue to talk on these two lines again and again, unless and we do that, I feel these barriers are going to be there forever. Apart from whatever the barriers been enumerated as Dr. Vijay Kumari. And how much does the statistics of WHO echo? I think WHO doesn't specifically talk, but it says around 62 million in terms of Indian thing. And also, Sarika ma'am has told about 275 million people with various categories of visual impairment. And Indian statistics of 2019, which was done and released in 2020 February, has shown around 13.76, almost 14% of people of the population in 2019 is around 137 crores. Out of that, around 14% of the people have visual impairment. It doesn't say what exactly, but they have given one category saying that functional vision loss of almost 1% of the population. Probably that will help us to calculate. Maybe I think any other answers, I think I'll appreciate from Vijay Kumari ma'am and Sarika.
Yeah, the overall prevalence will be 1%.
Yeah.
All studies, across all studies. So our own population-based studies show it is 1%. So whenever you do you screen or you do all these programs, you know that it's going to be about 1% of the population. 1% not treatable. Because if you include the treatable, the cataract on, then that escalates, right? But I'm talking of the not treatable. So that is 1%. That's usually about 1%.
Yes, ma'am. Next question to Dr. VK, ma'am. What is your take on the training the entry-level optometry students and as vision warriors?
Wow. I think I don't know. I don't know. We don't have this in our country, but we've had these students come from after they complete their optometry. They come from different parts of Africa, Nigeria, Zimbabwe, all that. Okay, and I think one of them, couple of them, I think that was probably from Kenya or Nigeria. I don't remember. Some time ago, more than about 10 years ago, they told me that they have this mandatory service, So I think about 6 months of service after you finish your course, you have to go and serve the country for whatever, some service, some mandatory service. So I don't know, it is easier said than done, these things, huh? Because as a part of the MBBS also, they make it mandatory that you have to go and serve in the rural areas. So if we make that a part of the curriculum and say that by rotation, it is mandatory to serve in the rural areas for at least about, let's say, 3 months, 6 months, whatever you decide. That decision is can be taken. But then what happens is we get exposed to what happens real life in rural areas, because we can sit here and talk in the comfort of our offices, we can do everything. But then unless on the ground, what is really happening, unless you're going to dirty your hands, you're not going to know what is there and what are the challenges that are really there on the ground. So yeah, so I'm all for optometry students, entry level, whoever, whatever, it doesn't matter. Like I said, I think the skill set is secondary. It is very easy to train people, right? But I think it is just the attitude. So I've had over the years, long ago, somebody told me that I will do low vision when I'm about 50. I'm like, why? I said, no, I've left that for my old age. So I've had these random funny answers, So I think somewhere, we are not getting the message across to our own people, regardless of whatever age group they are, whether they are starting, they're ending, that's secondary. But I think they are not. So I think the messaging is not. I think we failed in getting our message across. So I think that is where we've been a failure. I wish we could message it better, and I think we need proper PR people around with us, who can really do the messaging for us. And so I think, yeah, that is where it should be. Community library of low vision services. Wow. Okay. Yeah. I'll answer this before. I think I don't know whether it is. I don't know whether this is the challenge. If it is access to the services, I'm not sure, because at least these days, for the last, I think about 4 or 5 years now, every people at least who are up to about 45, 50, 55 years of age, they'll come and say, I'm managing with my smartphone. So you'll take Zoom, they'll Zoom, and they'll take text and all that. And so much literature. I'm talking about the moderate vision impairment. So they are, and the blind anyway will use the sensory substitution skills. They'll use auditory. They are well served. There's no problem with that. And the moderate will always use these smartphones and all those things. So I am not sure if it is just the access to the low vision devices, which is the bigger problem, because you can create a library, like you can have these libraries that we have for books and all those things. You can have it, but I am not too sure if that is where the stumbling block is. I'm not sure about that.
Yeah, I think I do second the thought, but I was just wondering probably what the different agency you are talking about can come together and do is to create maybe to start with, create some kind of centers as a group, as an association coming together and try to see that group of optometrists offer this kind of low vision services, say across Tamil Nadu, across different states and take that responsibility instead of giving only to hospital, because hospital can cater to some extent. Not every hospital can cater everywhere. So there I feel the associations can come together, can have a simple objective, whether we can try to offer primary care service up to secondary care services kind of it, where the individual optometrists in their location can offer the generous kind of service time to these kind of service. It will be a great achievement. I don't know, community, maybe naturally those places will have adequate low vision devices so that people can access to it any part of the day. So true, actually, one side, I also agree probably why this question arises. There are places down south and there are places even closer to Chennai. They feel that they are not, first of all, aware of this. I feel the awareness is not because of the people, because none of the eye care professional tells about it. If they tell, naturally, optometrists will procure, opticians will procure a lot of these devices and keep, because that's how things will work. But I feel it's a great idea if a group of optometrists under the aegis of the OATN or AAO and with the guidance of Vijaya Kumari, who have got a huge experience, Sarika, George Abraham, all these people can come together and kind of guide. And maybe this will be a great exercise to really implement.
And the other thing can be, like I said this earlier also, we can have on the India chapter of AO, at least the directory of, like they have it for the AO. So you have a directory of low vision care providers, right? In whatever form, primary, secondary, some form, something you're doing now, that is important. So if you have that directory of, so suppose today I want to send one patient to Uttarakhand, what do? I can't. So patient is from that side, they have to, it is glaucomatous optic atrophy, nothing can be done. But for what they have to come here? But I can't tell in Uttarakhand something is there. Let's say even O&M training only, no problem, even just for that. So I think just that that directory probably I think will make a difference, because and then what skill sets and all those things. So, and even if that person doesn't know, at least they can ask, teleconsult, something they can ask. So I think like I am going on saying this. So this hybrid model will work, So you can retrain them. It's not necessary that I use my grandfather's class and then keep practicing. I can retrain myself, right? It's hardly maybe a week for somebody who are in there with 10 years of practice, 5 years of practice. It'll take hardly a week to retrain. So it's not difficult at all. So only those other, that 20% is something that probably only those tertiary centers need to do. 80% can be done by everybody, So whether you're beginning, you're a student, it doesn't matter. I think it has to be hammered at the training stage to say what is the importance, because I always say this, one day it could be you, That's why you have to learn low vision, not for anything else. You will be old someday, so you never know which day it will be. So learn for that sake. It's nothing on anything else you don't learn. So yeah.
Ma'am,
Yeah, I think other thing which probably I think yesterday even George Abraham was talking about the highway initiative. I feel that is another thing which we can do it. At least people to bring in awareness, to tell about what are the available, what are the available treatments, available rehabilitation things, centers. Maybe these things definitely OATN this collaboration can do. Why not they can empower some of the visually challenged who are looking for the job under these ages. I feel a lot more that we can really do, so that indirectly we are also trying to becoming more and more aware of this important area and try to spread and see that at least a day can be spent every month or at least fortnightly will be a great initiative to start.
Like I said, that low vision society or something, na?
Yeah. I think that will be a great.
That if it started, na, we can bring that under ISLR then, International Society for Low Vision Research and Rehabilitation. So, I think
OATN should try to look at this. I think immediate need. It would be a great start.
because I'm in the executive board, so it's not difficult to talk to them about this and make that a chapter of whatever ISLA is.
Oh.
So yeah, I think but it requires some effort. So that's the problem there.
Maybe the president can give a view.
Good. Nice.
I'm super happy listening to all of you. Basically, I mean, this is how leaders like you can take us. So definitely, I've already sort of parallelly messaging Manasi that we listed down and take it for a separate discussion and move forward with some of the points for execution. Because now there are people like Devi and Ajita ma'am and all of those people who are already like into providing services. So definitely, we will take this up and. We'll use your leadership, ma'am. I mean, Dr. KK and VK, you just sort of like guide us, and then we will take it.
So Sarika has asked this question if it is profitable. I know of people who do business only low vision, right? It is very profitable. They make 100 times of what I make.
I just want this from your mouth, ma'am.
Yesterday, one patient came and told me, yesterday only, what are you sitting and doing here? So I just went to Calcutta, ma'am, and the guy is making 100 times of what you are making here and has space of not even 1% of the space that you have. So I always say it is not about space. It is not about those 100 people that you need, right? It is just about getting, I think it is being compassionate, using, not having an acid tongue. That does wonders. And being compassionate, understanding what the patient really needs, and just answering and doing only that, just that. And it is very, very profitable. Some of the leading businessmen are doing only low vision in the country,
Many times it is not recognized in that way, ma'am. People think it is like not a profit.
No. I think that's why I said, I think it is the messaging which is the problem, right? We've not been able to get our message across. So we've been doing a bad job at that. But if you get the message across, it is very, very profitable business, right? So I don't know why people say this, And they say, oh, it is very laborious, it's time taking. No, it is not time taking. It doesn't take more than 15 minutes, right? Refraction itself will take 15 minutes. So.
When you give these kind of motivation, there will be lots of primary eye care professionals and private practitioners.
There are people, their antenna will stand, oh, business. I tell them.
That's why I asked this question. There's a reason for this.
I tell these people I didn't do any of that, but please, right? I may be the wrong example. Please, right? Go ahead and please go and see. There's a lot of business in this.
At least start.
Yeah. Right.
Yes, this is Devi. I just wanted to add on a few things. There is no question actually, Rizwana ma'am. I hope my voice is clear.
Yes, Devi, you are clear.
Yes. Just that all we are talking about training the students and everything. And training actually happens in undergraduation, I guess. We have to start somewhere. Thanks to my teachers and my friends who have actually motivated. I am one person who have started with a very basic kit. I think Ajita ma'am would agree with me. We have started with, once a week, as Dr. KK mentioned. It is a very small practice, and we along the way we got support whenever we required. We got patience, and it is very easy for everyone to start somewhere. That is what I want to insist. The the optical outlets are now transforming itself into eye clinics, primary eye care centers, even equipping themselves with fundus cameras and many more. Why can't we? Why can't a basic low vision kit be present in all these outlets, in all these private practitioners? So it is like taking care of the community around them, so that the growing demand is met, not just by referring and by starting and practicing low vision care to some extent.
Yeah, and to add on to this is Ajita. Actually, some person was talking about low vision devices library. So I have a small thought on it. Maybe if the devices are the basic kit which Devi was talking about, if it is made available in the local public libraries, wherein there is a lot of footfalls and there will be a little awareness also made in, it would be better. That would be also a better place to equip with the basic lotion kit. The basic things which a person can feel, handle by themselves, and try to use them so that it creates a better awareness also.
Just to add, the students have to actually come out and seek low vision care as one of the specialty, in addition to, I think, contact lenses and many more, binocular vision. And recently, whoever student I interact with, they want to opt for binocular vision and they want to opt for many more, and just resolving to low vision care in case of research. I really want some practice has to start from students point of view, because they are the ones who are going to travel around the world and going to take their practice with them. So it's my honest request to the students.
Good, Devi. You have a large heart. You have space in your heart. You don't need any space. Like I go on say, you don't need space, darling. All you need is space in the heart, which you have. Right? That's about it. You don't need anything more than that.
Thank you, ma'am. Thank you.
அவ்வளவுதான் வேணும், இன்னும் தேவையில்லை. நீ வேற போய் I have a small space, I have, yeah, right, no, you don't need any of that, right? Infrastructure is secondary, right? I think it is just the attitude that is important, and the right attitude, that's sufficient. Everything else will fall in place. They are all tidbits. They can be worked on very easily, but so people don't get this. They put the infrastructure before the human resource first, and that's where they have a problem then. So I always say that I can stand on the road and practice low vision. I don't need any space and all that.
Exactly.
Yeah. So that's what I'm saying. Like Krishna Kumar is doing. See, you don't need big things, right? All you need is the right attitude and compassion. That's about it. And you will be known, people will come flocking to you. 200 square feet, 200 square feet space only, people are doing wonders. Yeah. So just don't go by these things, in that center they have that huge space and 100 people there. That is not required. That is required only for the 10% of the population, probably. 80%, 90% is right outside.
Exactly.
So don't get carried away by these things.
It is.
What you're doing is so important,
Yes, ma'am. Yes, ma'am. We have got infrastructure now, and because of COVID, it has been the patients have been less, but the footfalls have now increased, and we are seeing we need to at least equip. That's how we did. We need to at least have one device as a demo device. Then we can get. It is more like a refraction unit.
Yeah.
It has to be a mandatory unit. The basic kit has to be there in all outlets. Then the practice will start in a very easy way. I just want to share my experience with an opticals. Okay, I have 1 year of experience with an opticals. I tried nearly for 6 months to get at least the spectacle magnifier. So what happens with spectacle magnifiers is prescribing a +4 ad as a near vision glasses is it's nearly double the cost for a +5 half eyes. So I think the practitioner has to at least equip with the higher end magnifiers, and even suggest some higher ad in addition to the glasses. Yes, they have to take care of their own model of prescribing glasses, but just giving a low vision device as an add-on will actually increase the performance of the patient, more like a secondary device. In that way, their optical business is not going to be hampered. That's what is my view.
You're in Chennai. You're practicing in Chennai.
Yes, ma'am. Yes.
Oh, I see. So I think the messaging, because we are changing lives, through that you're changing livelihoods, and more often than not, it is that single sole breadwinner of the family that is getting affected, right? So the entire family, the economic burden, I think the messaging has to have those important words, So it will require some championing. Some champion is required to get that messaging right. And once that messaging is right now, then you'll have the younger generation. Like I told you, people have told me that they've reserved low vision for when they're older, it seems. So obviously it's not their fault. It's my fault because they didn't get my message right. So I am at fault. It's not their fault. So I don't find fault with them at all. So yeah.
Yes. And I hereby thank my teachers here, because my friend Sarika has been a very good teacher to me, and KK sir had all my third years and fourth years had spent with the camps and everything. It is just, I think this notion which we got from the college has been traveling. We are doing a very little part of what you are all doing, but that actually makes a difference in our lives. Rather than the patient's life, it is our lives which is transforming. Thank you.
I'm so glad to see you, because what wonderful job both Krishna Kumar and Sarika have done. See, wow.
Yes, sir. Yes, sir.
So proud. They are so proud of you. You see.
Thank you.
Thank you, ma'am. So the next question is, many reasons for not practicing low vision services is the non-availability of equipments. Can a central agency or OATN or AAO India can produce low-cost equipments and aids to be distributed to practitioners along with training sessions?
I think the question should be to the president of OATN and the AAO India chapter.
Yeah, you're right, sir. You're perfect. So,
on behalf of the India chapter, will take my question. I mean, because I need all of us actually.
In fact, already Vijaya Kumari ma'am told, actually, she's given a suggestion. She can, if we can come out with some specific proposal, I think she could really facilitate the process. That's what I understood. I think that should be done with international.
Yeah.
And the question to Ms. Sarika, ma'am. What is your patient selection criteria for VR, and how is the acceptance compared to traditional aids? Also, does VR provide instructions for the patient to perform a task, or does it actually magnify the image? What's the mechanism?
Yeah, actually, thank you for the question. Patient selection criteria as such, for my PhD, I wanted to start from 18. I had not touched upon less than 18. So 18 to 60 and above 60 also, like now we are trying. And I think the question is for VR or AR, because AR is the one which will magnify the image. VR is same criteria, 18 to 60. So because only the exclusion criteria will be those who have claustrophobia and epilepsy, all those sort of things, but we have not tried on them. Otherwise, no issues. And many times I would say, as persons with normal vision, normal depth of perception, we have a little bit of doubling of images when we don't correct it for our IPD. But patients with low vision, if you see, that is like one wound that they have. Many of the patients they will not have that much of depth of perception as we have. Majority of the times they will be using only one eye. So that is an advantage for them to use this AR. So they don't have this dizziness or doubling or headache that a normal person will get. So usually people, those who play with VR games, all that, they will have a little bit of headache after for 30 to 40 minutes of use. But fortunately, low vision patients, we have made them work at least continuously for 20 to 30 minutes, and we give them some task and ask them to perform. They have not felt any of this, except for the, it will not be too heavy also. It will be less than 40 grams altogether. So maximum of 40 to 42 grams, that's it, less than 50 grams. So it is not very heavy also. So regarding magnification of image, it gives you more than 100 times of magnification. for distance and near. And the major advantage of AR is you have to take many devices. Like for distance, you have to take, for example, CTV. Near, you have to take another CCTV. So all put together in one package. So this one device helps you for distance, intermediate, and near. And this is the biggest advantage. And the wide range of magnification that this device gives for distance, nothing else gives, up to my experience. There are so many for near. And I wanted to have one good device for distance because there is no such CCTV kind of head mounted display for distance. So this augmented reality device helps them for better distance vision. So that's where it is best. And recently we saw a kid last week. That kid had come for a contact lens trial. Thus 10 years old, and that patient had one eye in OPL, other eye complete corneal opacity, CF vision. And fortunately, since I have been with a very good rapport with all the department heads, that CL practitioner brought that patient to the low vision clinic for trying the AR device. So being a 10-year-old and just CF improving with Boston K lenses to CF50, with the augmented reality device improved to 612 and 6. So the person is not even a low vision according to the definition. So he's actually going to a blind school. So the parents were very happy and the child was very happy, and they were like sitting in the low vision clinic, I will get this device, then only I'll go out of this room. So we were all like little stuck because that was the first 10-year-old we are trying. Less than 18, I was not taking for any of the studies. So first time we were like doing lots of other experiments to think and decide whether to give him or not. So this is the kind of happiness and improvement and enhanced image it gives for the patients. So it is like much better than any other device available. I think I answered your questions. So yes, in terms of accessibility also, people are like getting used to it very easily because everyone is using smartphone. It is nothing but a smartphone only. So it is like a more like a wearable device. Your hands are free. So they are very happy with the device, everyone. And can government or other agencies help the people with low vision to buy devices? Yes. Tamil Nadu government helps with a portable video magnifier worth around 11,000 rupees cost. They are giving this at free of cost for school students and college students from the year 2013. So it is very much available with them. When we give a letter or any other special educator or an ophthalmologist give a letter to the patient, they go to the DMS office or the nearby district disabled rehabilitation council or the officer, they get the device at free of cost. Apart from that, there will be lots of NGOs who can help, and we do get funds, and that is how we help for all the non-paying patients of Shankarantralia. I think that's it.
And the last question to Dr. VK ma'am. Many times people with low vision.
Yeah, she answered this.
Okay. Ma'am. And the last question in the chat box. What are the basic instruments for demo to teach patient need to start practice? It's from Arka Ghosh.
Sarika and Vijaya Kumar madam.
Actually, ma'am showed one picture, no? So that is like a low vision kit, ready-made kit. You get it, yeah, from the slides. So Dr. VK ma'am showed that. So there is a primary low vision care kit. We can help with that. So it is ready-made, available from LUPA. You can get it from there. Or the list of devices, we can definitely help.
Thank you. And yes, I think there are no more questions. I would like to conclude the session with a vote of thanks. And so now that we have come to this end of the session, I feel so ignited and inspired by listening to the legends of low vision as a young mind. And so on behalf of AAO India chapter and OATN, I take this opportunity to thank the esteemed speakers, Dr. R. Krishna Kumar sir, for sharing his experience in providing home-based low vision service, and Dr. Vijaya Gautwal ma'am for enlightening us with the importance and the various levels of primary eye care in low vision, and Ms. Sarika ma'am for sharing the evolution of low vision care and also the real experiences of low vision devices of the patients. Your words in the presentation has helped us to magnify our knowledge in the best possible way. And I would also like to thank Dr. Jamil Reswana ma'am, President of OATN as well as AAO India chapter, for initiating and planning this event, and Ms. Preeta Ramprasad and Dr. Aishwarya for the back-end support, and Ms. Purnima for taking care of the multimedia activities. I would also like to thank each and every delegates and attendees for their presence and contribution to make this webinar a great success. So I would like to end this session with a quote. Low vision eye care is not just to improve their vision, but also enabling their independency and to improve their activities of daily living with a happy and confident way. So as an eye care practitioner, it is the smile of the patients we long for. Thank you, and good evening and good night to everyone.
Thank you.
Thank you.
Bye-bye.
Thank you, everybody.
Bye.
Thank you. Thank you.
Thank you.
Thank
Bye.
you.
Bye.
Thank you.
See you.
See you all. Bye.
Nice to see you all. Nice to see all of you.